an old agenda. The good news is Mike Borger has already talked about that, so I'm going to talk about how confident is the TAVI guideline shift from operator risk to age alone. So these are some of my TAVI conflict of interest. The good news is I'm pretty much spread with my conflict, and I consult for all these companies. But my other conflict is I'm a cardiac surgeon, and that's what I spent my life doing, is cardiac valve disease. So we've already talked about the U.S. guidelines. The U.S. guidelines say that if you're over 80, you're going to live 10 years or less, you get TAVI. If you're 60, you're going to live 20 years or more, you get surgery, and in between, it's the physiologic risk of surgery, the anatomic risk of TAVR, and what the patients want, and of course, all the patients want TAVI. The European guidelines are a little bit different in that they talk about age and risk, but not life expectancy, and draw the line at 75. Less than 75 and low risk, which is a Euro score of less than 4, then you should still have surgery. Higher risk or over 75, you should have TAVI. So this is what's going on in the U.S. right now. You've all seen this slide. This is updated to 2022. Of course, the red line that's going down a little bit is isolated aortic valve replacement. The blue line is all aortic valve procedures. And that orange line going up is TAVI. So in 2022, we did 98,504 commercial TAVRs. In 2023, we did over 100,000. I just haven't updated to that. Of interest, if you look at the red line and the blue line, isolated AVR and overall AVRs, in 2020, after low risk got approved, we're actually seeing an uptick in surgery, probably because people are now coming into the valve clinics and people that are following the guidelines are operating on these people. But you've also seen this slide. This is the Vizient database, which covers 95% of the academic centers in the US. And what they did is divide up their isolated aortic valves into less than 65, 65 to 80, and over 80. And right now in the Vizient database, which is the northern Atlantic part of the US, almost half the people by 2021 were getting TAVRs that were 65 or less. This has been repeated in California and several other places, and the data looks the same in multiple locations in the US. So the real question is, well, what is the risk of surgery if we're going to operate on these people? How long is the patient likely to live? Do we have data durability that will help us make a decision? And what are the options and risk if we do SAVR or TAVR and one of them fails? What can we do to rescue our patient? So what is the risk of surgery? Well, if we look at surgery and we compare it against TAVR, because if we just look at surgery alone, there was a recent article that Mike Borger showed you from the Annals of Thoracic Surgery where they looked at low risk isolated aortic valve replacement in the STS, and they showed that they had a mortality for 74-year-olds at 8 years of about 12.7%. The problem is, if you look at the consort diagram, when they went down there, they lost 1/3 of their patients they couldn't match to the death index, and so they just kind of ignored those. And when you ignore the people you lose to follow-up, those are the people that have more deaths in them. It's hard to judge that, so we go back to the randomized trials, and there are two randomized low-risk trials. There's the PARTNER 3 trial and the Evolute low-risk trial, and what you see is that it's non-inferior in both of those. They kind of cross in PARTNER 3, but they're still non-inferior. They're on top of each other, and then they're splaying, but they're still non-inferior in Evolute 3. I hope to present the 5-year data next year at ACC, and we'll see what's going on at Evolute at 5 years, where these are starting to flatten out or they continue to diverge. And this is the recent Dedicate randomized trial from Germany, looking at lower risk patients. And what you see is that TAVI did much better for a cumulative incidence of stroke or death of any cause than did surgery. But when you read this study, the mortality in the surgical group was about 6.5%, much higher than you'd really expect for this group of patients. So we know that TAVI has pretty good early data. We know that TAVI does okay to about 5 years, and we know that the NOTION data looked okay to about 10 years. But how long are these patients likely to live? Well, if you look at the randomized trials, these are the high-risk randomized trials, the intermediate-risk randomized trials, and the low-risk randomized trials. And if you look at the mortality for the randomized surgical arms, the straight red line and the dotted red lines are PARTNER high risk and intermediate risk, and the dotted line at the bottom is a PARTNER low risk. Of course, if you go to higher and higher risk, your individual risk of mortality in any single day is higher, so your cumulative mortality at 5 years is higher. And you go through the blue lines, and that's high risk core valve, intermediate risk core valve, and low risk core valves. And of course, it all has to do with the risk of the population that you do the procedure on. And the same thing looks good for the TAVR arms. In the TAVR arms, they basically look exactly the same. Why? Because it's the risk. Once you survive your procedure and get rid of your aortic stenosis, your long-term survival is going to be based on your individual risk and the performance of the valve you got, whether it be TAVI or surgery. So we know that if you had a high risk, your mortality at 5 years is 50% or higher. Well, that's why people that are above 80 really can get TAVR. They're not going to live long enough for their valves to wear out. I really think some of the best data, though, comes out of Sweden. In Sweden, every aortic valve procedure is data-based by law. Every death is reported by law. And so they know what happens to every isolated aortic valve, and they have every death that's accounted for. So what they looked at is they looked at patients that are over 60 with aortic stenosis who underwent an isolated surgical aortic valve replacement with a bioprosthesis, over 8,000 patients. Then they risk stratified them into what were low, intermediate, and high risk cases, and then they divided them by age in 5-year increments. And this is what happens if you look at the low risk, the blue line, the intermediate risk, the dotted line, and the high risk, the black dotted line, over 15 years. And it's exactly what you'd expect. The higher the risk, the higher your cumulative mortality is at any point in time. So then they divided up by 5-year age groups, 60 to 64, 65 to 69, going up from the bottom up. And you see as you get older, you're going to live less long. Your survival is based on how old you are and how sick you are at any given time. So then they could take these and they could do mean survivals. The high risk is the black line you see going through the green at the bottom. The intermediate is the red line. And then the blue line going up there at the top is what happens in low risk. And I think we have durability data based on what we've done already to about 10 years. And you notice the high risk and the intermediate risk, the mean survival barely hits 10 years in intermediate risk. But once you get to low risk, it actually doesn't get down to the green bar until you're about 76 years old. So do we have the durability data that would then let us move on and do these things? Because we now know what the survival is. Well, this is Philip Peeberow's work from Partner 2A, which was the intermediate risk, where we randomized XT, which is a previous generation of the balloon expandable valve, against surgery. And if you looked at the biologic valve failure, there was more in XT than there was in surgery. It wasn't a surprise. It was an early generation valve, and I don't think many of us were very happy with XT as a valve. And then they took the non-randomized continued access S3 arm and they propensity matched it. And what they showed is that the failure rate for S3 was about 3.9, for surgery about 3.5. Statistically, that was exactly the same. So this was considered a win for TAVR, that the durability at 5 years in this intermediate risk group appeared to be as good as surgery. However, if you go back into the supplement and look at the last table in the supplement, they actually did an inverse probability treatment weighting analysis of this, which is another statistical way of looking at this, and it allows you to create a better, more accurate pseudopopulation by kind of cutting off the tails of the curve. And if you do that, you actually see in years 4 and 5, S3 had statistically more valve failure than surgery. A little bit concerning. I did this with the core valve high and intermediate risk. What we did is we took the randomized arm of the high risk core valve and the intermediate risk core valve, over 2,000 patients, and used these randomized patients to look at the incidence of moderate or greater structural valve deterioration. And we use a subset of the VARC3 analysis defined as an increase in your mean gradient of 10 millimeters mercury or more, and a final mean gradient of 20 or more, or new or worsening intraprosthetic AR to moderate or greater. And what we found is that by 5 years, the rate in surgery was 4.38, TAVR 2.20, for a p-value of 0.004. So when I presented at ACC, this actually got a lot of buzz because at the time, surgeons would always say, well, listen, you got to use surgical valves because we have the valve stability data out here. And here's the first time it looked like maybe TAVR had less structural valve deterioration than surgery. Then we took the non-randomized continued access arm of both those trials, which got us up to over 4,700 patients, and used that larger number to look at the clinical associations if you had moderate or greater structural valve deterioration. And what we found is whether you had TAVI or surgery, if you developed moderate or greater structural valve deterioration by the definition that we're using, it doubled your all-cause mortality, it doubled your cardiovascular mortality, it doubled your risk of being hospitalized for heart failure or aortic valve reintervention. So when we write these definitions, such as PPM or structural valve deterioration, we write them to correlate them with clinical outcomes. And this is one of the first times we really strongly correlated something with clinical outcomes. Steve Yakubov then went back and said, let's look at overall valve dysfunction. Overall valve dysfunction includes structural valve dysfunction, non-structural thrombosis, and endocarditis. And what Steve showed is, again, using the same randomized data, and then the association, there was more biologic valve dysfunction in surgery than there was in TAVR. And if you had biologic valve dysfunction, again, it was a marker for increased mortality and increased rehospitalization. Now, the opposite of valve dysfunction is valve performance. What this tells you is that TAVR in this randomized trial had better valve performance than did the surgical arm of the trial. And this is, of course, the NOTION data. We've seen the NOTION data. This is now out to 10 years. Remember, it's a Nordic country, Norway, Sweden, Finland, and Belgium, with first-generation core valve against surgery. Mean age was 79, mean STS of 2.9, a little bit different than that. But what they saw is that 10 years there's no difference in the mortality. And yet using a similar definition of ours to moderate or greater structural valve deterioration, again, they showed at 10 years more in surgery than there was in TAVR. Now, I've done a lot of surgical valves, as has my friend Dr. Mack, and all of us have seen valves that failed early. I wrote my first paper on trifecta failure in 2017. The people who owned it then was St. Jude. They came to my office and said, please don't publish this paper. I said, no, we're going to publish the paper. And there was an editorial written to it, was this the canary in the coal mine? It turned out it was. Cleveland Clinic did a larger series. University of Michigan did a larger series. And this valve fails early. It's off the market. I put in several hundred Toronto stentless valves. They look great to year 7, and then they started falling apart. So what I want you to think about is structural valve deterioration is not a class effect. It depends on valve design and tissue science. And each surgical valve is going to be different, and each TAVR valve is going to be different. So it's really not a class effect. So what are the options and risk if surgery or TAVR fail? Well, this is from University of Michigan. What they've shown is one of the fastest growing operations they have is TAVR explant, or TAVR or explant after a surgical valve and a TAVR inside that. And if you had a TAVR explant in the University of Michigan, a really good valve-centric place, versus a redo aortic valve, it doubled your mortality. And what Gilbert Tang has shown us with the TAVR explant, it went somewhere between 2 and 3 times the hazard ratio for mortality. So these are not simple things. I think surgeons can learn to do them better. I did my last one on Wednesday before I came here on a 152-kilogram woman who had a valve put in that had become infected. We're getting better at these things, but there are tips and tricks. And just like it was hard for surgeons when they did their first redo aortic valve, once they've done 100, it's easier. I think this will get easier, but they still are complex operations. And doing over 100,000 in the US with many younger patients, for my younger colleagues, this is going to be one of their busiest operations going forward. And this is the data from both Bopat and from Gilbert Tang, showing that the mortality can be up to 10 to 13%, much higher than we would really expect. So how confident is the TAVR guideline shift from operator risk to age? Well, this is again what you saw. This is from the Sweetheart database. Again, the black line is high risk, the red line is intermediate risk, the blue line is low risk with median survival time in years. There's our line for 10 years. I think we have 10-year data. I think if we're talking about high risk or intermediate risk, that's pretty reasonable to do TAVR. There's where we don't have the data yet. And if you're low risk and below 76, you fall into this red zone. Here's the US guidelines, and here's the European guidelines. I think there's still a big area between European and US that's red that we need to work out, and there's a whole lot below the 65 that's red in US that we really have no data on whatsoever. So how confident is the TAVR guideline shift from operator risk to age? It really depends on the age you choose. If you choose the right age, I think Europe has got it, clearly works out well in Europe. And I think there's still some questions. I'm very comfortable in 70 or above. I'm 71. I don't really want to be operated on. I think I probably survive long enough. But when you get down less than 65, I do think that we're doing some disservice to some of our patients. Thank you very much.
If you would join us up here, Juan Granada is waiting for us in New York and is on a tight schedule. So we're going to go directly to Dr. Granada right now, and we'll save questions for